Yay, the internet's working today. Welcome. As we're waiting for everyone to join me, I just wanted to, for those of you who don't know me, and perhaps this is the first time that you've come to join me, I'm Kaleem Joy. I'm a licensed midwife and I'm a certified professional midwife, which is nationally recognized. And I'm also a certified pediatric massage therapist. And I get to do Facebook and Instagram lives every Wednesday night at 7 o'clock Pacific Standard Time. And we choose a variety of topics. There's a new thing I'm going to do over the next, say, month or so. And one is I'm going to go through a consult so that you understand better about what midwifery care is about. I'm going to bring in a brand new midwife and a student midwife to kind of talk about midwifery and how the schooling and how the progression happens with that. So this is a great opportunity to invite people who might want to learn about midwifery, or for all of you that maybe hadn't ever thought about it, to just better understand how that happens at home. And we're going to keep going on from there. I'm going to do a whole prenatal so that you understand what prenatal visits are all about too. So stay tuned on the feeds and I'll let you know what's coming up that week. But I really want to thank everybody for joining me tonight. This is an amazing topic to talk about, is talking about vaginal birth after cesarean. And when we look at our national, our nation, in the U.S., most birth givers, if they've had one cesarean, even still in many hospitals and for doctors, they want to do a repeat cesarean. It is beginning to become less and less of an issue, mostly because they found that cesarean deliveries, if they were encouraging them to people who just wanted to choose to have a cesarean instead of going through and having a vaginal birth, they had more problems, more complications, more bleeding, more mortality rates, infections, things of this nature, when it wasn't necessary. If it's necessary, it's a really wonderful tool. When not, we need to go back to what nature intended us to do, even if that means that somebody has medication. So I wanted to talk about VBAC because one of the things that having a cesarean does is it does set a woman, a birth giver, on a path. And that path is that if she's choosing to have her babies in the hospital, then she will be looked at as more of a higher risk. But you can have VBACs in many places throughout the United States. California is still one of them, at least for now, as of this date, where you can still hire midwives to attend you in having your babies either at home. Some freestanding birth centers may allow it as well, some may not. And so looking at a VBAC, and a VBAC is absolutely one of the things that should be given an opportunity in every woman. Now you always have an option. Anybody who's had a prior cesarean, any physician will happily do a repeat on you. But the encouragement is to really think about how that cesarean does. So let's talk about, how do you get a successful VBAC? First, I believe and have worked in the field for many, many years, and many years ago I taught for Kaiser, and I taught their VBAC class. And in their VBAC class, one of the things that I asked the families to look at is, how did the section occur in the first place? Sometimes it, and please join in, anybody who's on that would like to join into this discussion-wise. Most of there are, let's say if there's a breach, they don't want to do a breach vaginally, and so automatically they're scheduled for a section. So that's a scheduled section that could happen. If a woman has been told that her baby is too big and that labor shouldn't even be attempted, that they should just section, then that may be a reason that a cesarean happens without even labor. What other reasons have you heard of from friends, family, on the social medias? of reasons that were scheduled cesareans. If they've had one before, if they've had a breech, the baby's too big. Yes, premature babies, if the babies are under a certain week, such as maybe it's a baby that's 28 or 30 weeks or even younger, often a cesarean is the only way for the baby to safely be born because they're too fragile to undergo a vaginal birth if they're going to be living in the NICU for a little while. So what happens from there is, how does it occur? Perhaps a labor started because membranes ruptured and there was no labor for a period of time. Maybe it was 12 hours, maybe it was 24, maybe it was longer, maybe it was 2 days or 3 days, and they couldn't initiate labor. Labor just never got started. And they say, well, there's nothing we seem to be able to do. We've done all of the induction things. The baby's just not coming. We need to section the baby. Okay, so that's another reason. Sometimes if they think the baby's getting too big and they want to do an induction, which means that they want the baby to come early. And that could happen in somebody that has been diagnosed with gestational diabetes, or maybe they have insulin-dependent diabetes, whether that's from pregnancy or maybe that's what they have as a health risk before they even went through pregnancy. And the baby's getting big and they prefer to get the baby here sooner so that things go well. So an induction starts. And we know with an induction, if the body is not ready, we know that that induction is going to take quite a bit to help the body want to labor. And that means that often there is say cervidil put on the cervix to get the cervix to ripen up. In a holistic way, in a home birth practice, we use evening primrose oil. They might choose a Foley bulb, which is where they put a little catheter in the cervix, and they inflate a little water balloon in there, if you will, that helps put pressure on the cervix, creates a bit of weight, and it helps the cervix want to ripen up and dilate to get things ready. Because we know that until a cervix gets to a magical 3 or 4, and now they're saying 6 centimeters is more what active labor is, okay? So I want you to know ACOG, American College of Gynecology and Obstetrics, the people who make all the rules out there for the docs, this is more their protocol now, is 6 centimeters is what's considered active labor, all right? Not 2, not 3, but 6. All right, so the cervix has to be ripened, all right? So then the cervidil is put on. Sometimes they might use misoprostol or Cytotec. Some of you have heard, a little tablet that goes near there. Then they want to hook up an IV. They want to start Pitocin. They start it slow. It goes up every 20 or 30 minutes over a period of time until they max it out. They need monitors in order to monitor the baby and monitor the contractions to make sure that things are, number one, working, but also not stressing out the baby. And this goes on. And depending on how willing, especially with a first baby when nobody's ever been there, that may take a day or 2 or 3. And going through that much, often there can be the fatigue level and the stress level and all of that. And a woman or a birth giver may opt to have medications now. So now we've intervened with this labor a lot, right? Rather it's because there was a necessity for it, or rather it was doc was going on vacation and this birth giver wanted her baby born with that doc, which meant she was willing to go through an induction in order to have that doc there. Perhaps she's going overdue, by 1 week or maybe by 2 weeks or more, and that induction comes into play. Perhaps it's that labor already started and is progressing along but seems to get to a standstill. And maybe the baby is posterior, where the baby is turned with its face towards the same way that the birth giver or the mother is facing. And those babies have a harder time helping the power and the passageway to work well. So there's all different scenarios that are in the story. And when I work with women who have had a cesarean in the past, there's a physical reason, there's an emotional, there's a spiritual, there's a mental, and it comes from what has been the story. So I always want to find out, how did they get to having a cesarean? And what were the things that occurred? Because when you can find the various pieces, whether it was the induction was started and why, was it a reasonable induction or was it perhaps just protocol? And how do we go back and say, now, what do we need to give guidance and education to this family for to help prevent the need for an induction? And then if it was a labor that started or even an induction that was started, where did it hit its ebb? And when I was teaching VBAC classes, I found that women would get their sections at certain dilations. It was either 3 centimeters, 3 to 4, it was around 6, or it was around 9. And sometimes, it was pushing. So I found that there were those key points in labor where we know that there is a transition that happens in each one of those. There's that little plateau that moves into the next part of labor. And perhaps it was a time that needed more privacy and other things that encourage a woman's body, a birth giver's body, to do its job well. So when you look at how the story occurred and you go back and look at the scenario and the course of events, because maybe it was infection that happened, because maybe the water was broke by the care provider at 2 centimeters to start labor. Labor didn't initiate by day 1.5 because they were checking so many times. There's now an infection. There's antibiotics. The uterus does not like to work as well when there's an infection or an inflammation going on in it. And the baby, right? The baby's position. So when I go back to basics and I say, all right, let's create a new story. I tell them every single baby has its own story. Even if you've had the best birth, the next baby's going to have its own story. You'd like to take pieces from the first story and move it over, or maybe you don't want to take pieces and move them over. But you have to know what the story was that created that journey. And once you do, you can understand how to create a new story. So many times if we've had a woman who's been in a hospital, and let's say there's been a lot of interventions, a lot of things that occurred, and then she finally ended up in a section, sometimes they have understood that their best chance is to go back to nature, which usually means coming to a midwife, and go back home, which means having the baby at home or in a freestanding birth center if they allow it, and be able to say, I want to do what my body was made to do, which is to be a birth giver, a good, strong birth giver. Now, in order for birth to happen, there are some very basic key elements, and I've mentioned this in some of my other lives. One, you have to have the physical working right, and that means that the pelvis is flexible and moving. When the pelvis is flexible and moving, then that allows the baby who's in the pelvis having to navigate to get in a good position, which means back up front, chin tucked, crown of the head coming through, which then allows it to sit down on the cervix and help the body to get the signals to want the power to work well. So on a physical level, you need a flexible pelvis, a baby in a good position, and the power working and being strong. The other factor that works into this is the emotional side. So going forward with birth, one has to have a mindset that they are willing to trust what their body is doing, accept the sensations, accept the power, working with it and following along. When you do that and you set your mind that you are going to be the birth giver, taking the ownership, being the person that is empowered, and surrounding yourself by individuals, your care providers, your family, your friends, whoever it may be, who also support you in having and following what your body knows how to do and what the baby knows how to do, you will maximize your ability to have the best, not only birth, but the best VBAC. So often the most common reasons that cesareans occur are either from long management of inductions, and this is the statistics according to Kaleem, okay, of what I've seen, what I've heard, what I've read about. Go do your research. Is from inductions and the cascades of events because women are not ripe and ready to birth. The other is from scheduled inductions because of whatever those reasons are we just mentioned. And the other is having a great birth that is progressing and then technology is put into it, such as a birth giver is gone into labor at home, she's moving around, they're doing things that are helping the labor, they decide, okay, it's time to go into the hospital. They go into the hospital and they become a patient. And when they become a patient, that by technicality means one who suffers. And one who suffers means that they need to be helped to stop suffering. So going into a hospital, if that is where your philosophy is, because that's where you feel safe, great, no problem. You just have to understand why you're going, which is not to use any of the technology unless something in your birth needs it, okay? Which means you go into that beautiful big pink bubble, you go in, you stay within your space, you move, you groove, you rock, you roll, you get on the birth ball, you get in the shower, you move about, you listen to your music or your hypnobirthing. You have people there that are there to give you comfort as well as encouragement and keep you on your path and work with you so that you can do what your body and your baby were meant to do. When interventions become part of a birth, there is a risk of complications, and the cascade that follows the path then can lead to a cesarean section. And that is where I want you to always realize how to rewind a clock and figure out where did the cesarean start so that you can make different choices. So one is hire a midwife, have your baby at home, because a hospital is always ready. Okay, we're going to talk about the whole deal about rupture here in a minute. A hospital is there 24/7, 365 days a year, and they're happy to help you, and they're happy to section you at any time. So if you go and you interview with a midwife, and it's a skilled midwife who feels confident about doing VBACs at home, that is one option to having a great possibility. One, emotionally, you're going to get that help to work through those processes. Two, you're not being subjected to all of the interventions that go on. And three, on a statistical level, if you look at midwife statistics, they are very good at having successful VBACs at home in looking at how many happen at home. In my practice, in our practice, our One Heart practice, when we have VBACs, I would say we're at a good 80 to 90, I would say closer to 90% if they've had a VBAC before, if they've had a cesarean in the past, they will have a VBAC at home. Sometimes they transfer in and they have a vaginal birth, and sometimes they transfer in. They attempt to have a vaginal birth in the hospital, and they do end up with a repeat cesarean. So the other thing is, if you're choosing a hospital birth because that's where your comfort level is, great. You need to follow those same steps. Get a birth ball. Use a massage therapist to make sure that pelvis is really good so that your baby gets in a good position so that you maximize your opportunity. You need to hire a doula or a midwife who's willing to follow you at home and into the hospital and be that support and encouragement and help you to have a successful VBAC in a hospital setting by keeping those interventions to a very, very small minimum, which means monitoring the baby, and that's about it. Some hospitals require that you have an IV in. They usually can do one where they put a little stopcock on it so that it's in, but you're not restricted and you're not connected up to a bag. They do want you on monitors though, pretty consistently, which, all right, you have about a 6-foot lead. Go with that, okay? And so having that in your team gives you the ability to feel like you've got the best of the best if you're going to go into a hospital setting. And if you're going to birth at home, you have the best of the best also. You have all of those options open to you. Now, I realize that some of you may not live in California, and some people may not have access to midwives. There should be doulas in your area somewhere. And if not, find someone that can really be a good support to you. The other is stay home until your labor is well established, right? And that means that there's a good 5-minute pattern, 60 seconds long before you go in. And for us, it's even, we're there, we're able to monitor and go through that. Oh, that's another thing I'm going to do is open my birth bag and everything up to tell everybody, not tonight, but on another live, so that you understand what all we bring to a birth. So having that success depends on those factors. It is know where the cesarean began, get each of those elements, the passageway, the passenger or the baby, the power, and the passion or purpose in your heart and your mind, all in cooperation with one another, that they believe and trust in knowing that you will be able to have a VBAC. Now, if it was your first baby that you had a cesarean on, the only thing you have is that birth to tell you what birth is like for you. And that's where it really takes that mindset to have to really recreate a new book. So you start by writing, what do I want to have in my birth this time? Not, I don't want this, I don't want that, I don't want this, I want that. Go ahead, write it all down and then put that aside and change all of those I don't wants into what do you want. Such as, I don't want people coming in all the time and constantly offering me blah, blah, blah. Put down in there, I want people to come into my room, smile, do their job, and leave me alone. Whatever that is, right? Or I want them to come in with a positive attitude. And that's what you put down in your birth plans if you're going into a hospital setting, and make that birth plan very brief. It needs to have 10 bullet statements on it and no more, okay? Because they most of the time will not read them, or they may or may not feel that they're, valid. I don't know. All right, so let's start getting a little more feedback. I know all of you have had friends, and some of you may have had family. Some of you may have had cesareans. Maybe you've had VBACs. I want you to start thinking about your questions so that in a few minutes, when I start asking for those questions, you can start feeding them off, and let's see how we can engage in a conversation with one another even more. So going in and having that encouragement also means you need a care provider who really is willing to let you go forward. Now, there's something called a TOLAC, a trial of labor after cesarean. That's what a TOLAC means, okay? And that's what the medical profession looks at, that they will give you a trial of labor. Please don't take that as those words. Those are really hard. It's as though you've gone to court and you've got to prove yourself innocent. You don't need to prove to anybody except yourself that you are strong and powerful and that you have all the means to being able to birth your baby, especially if you had a cesarean that was scheduled. If you had a cesarean for a breech, a baby that was too big, that they suggested was too big, that they said is going to be 11 pounds and it was only 8, if you had a cesarean for, whatever other reason that you were scheduled, you are having the first birth, and let yourself have that first birth. Now, here's a little tip about having VBACs. Because of where the scar is in the front and that they have to go through the muscle, when that heals, the muscle fibers there may or may not be as strong and have as much communication as they would have without the scar. So sometimes you can get what's called a cervical lip, or maybe the cervix is all dilated except in the front. And what that means is like if you imagine the baby's head, there's like this little lip that wants to stay over the baby's head, and until it comes back, which is the cervix, the baby can't come past it and come out. Those cervical lips, if you give them a little time, usually will go away. But you have to change positions, which is why if you're going to go for a VBAC, avoid medication if you're going into a hospital. You must trust your body and allow it to do the job that it wants to do for you. And your baby knows how to do this. Your baby didn't have a cesarean before. Did you know that? Your baby doesn't know about that. Your baby only knows how to be born. So that cervical lip, sometimes if you labor it in different positions, being on your hands and knees for a little bit, sometimes in a rocking chair, sometimes actually laying back a little bit so that it wants to pull forward without the baby pulling it down as the baby's trying to come out. Because the baby's like, I want to come out, I want to come out, I want to come out. And it drags the cervix down with it. If you can swap positions every like 3 contractions or so, it may go away on its own. But if it doesn't, and you've done that, ask whoever your care provider is, can you hold it back? I want you to know something. When that happens, when we are at home, because I tell women, these birth givers who want to have VBACs, I say, I want you to know about a cervical lip. Because if it comes up in labor and I say to you, that lip is what's preventing your baby from coming out, do you want me to hold it back? And if they say yes, I say, remember I told you this was not going to feel good. And they need support at that time, because when you hold it and it's able to be held back, that means that the cervix really wants to pull back, not that it's just not ready. When it pulls back and you push past it, baby comes out. And the cervix doesn't get swollen, you don't have to back up, because if you start pushing on a cervical lip, it's going to get swollen, and then it's going to take a few hours of telling you to stop pushing and being in a funny position to get it to go away. So just know that that's one tip coming from a midwife that I have seen that has helped VBACs succeed. Those cervical lips, change positions, and if you're on an epidural, that's going to be an issue because you can't change positions as easily. And an epidural causes your body not to contract as strongly, which means then you have to add Pitocin. When we start going to where is this surgical line that's in there, and everybody talks about, but what about rupture? Because that's the big scary word that everyone is worried about with having a VBAC. When you look really at statistics, there is a higher chance of rupture in a person who's never had a cesarean if their body has been pushed and pushed and pushed, like with lots of Pitocin and lots of stuff going on. So in statistic-wise, it's not as high as one would think. And last time I looked, which has been a little while, it was like 0.03%. And that's a really tiny percentage. So I want you to know you can trust this. And no matter where you're going to birth, whether it's at home or whether it's in a hospital, you're going to be monitored. And there are symptoms and signs that tell us that rupture is occurring. Is there a big what if that could happen? Of course. Anything can happen in birth. But the vast majority of the time, babies are meant to be born and bad does not happen. Okay? Now, that's where I can say there are no guarantees, and I understand that. And that's why if you're healthy and you take good care of yourself and you eat good quality protein so that your pregnancy is healthy, good quality protein along with good vitamin C foods, those help create collagen. And collagen in your body is what helps with elasticity. And the scars inside there, they want them to heal long enough so that the scar has good integrity. And the one thing that I've thought about, that we've talked about a lot, is that when you contract, it's going to pull it together. It's not going to push it apart. So that's where I think, it must not be quite the same as pulling it apart, because it comes up. The uterus and cervix come up into each other. So it's a wonderful, wonderful thing to go forward to have a VBAC. Yes, you are labeled. You are labeled a more risky delivery. Okay? When I look at VBACs, I know that. I know what the risks are. But if I have a healthy woman who is doing everything right, and the baby is well, and labor is progressing, things go well. Often when there's something going on in there, whether it's an infection, or the uterus has a problem, or there is some window opening up, it doesn't want to work right. That's what many times people see, is that the uterus is already telling somebody something's not right in here and we need to do something different. So get your mind set. Help those that you know to come back and watch this and get some ideas, get some thoughts, get some encouragement. Find a doula, find a great friend who's had natural births who wants to support you. Find a midwife, someone that you can work with. If you're going to a hospital, either hire a midwife to go with you, or come and sit and have a consultation with a midwife and say, I'm planning to have a VBAC in the hospital. I want to understand the best ways that you as midwives who do home births, how do you help prepare women, and how can I help prepare myself for going to a hospital? Okay, great. All right, let's move to questions. So I have one coming in. I have an unicorn uterus and had a cesarean because my first baby was breech. Would you recommend a VBAC in my case, or too risky because of my uterine anomaly? You know, that is a really, really great question. And I'm not sure I could answer that. And the reason why is that the type of uterus that you have, meaning that you have two sections to your uterus, I think that some of that would depend on whether it was two separate uteruses, whether you have a tiny small one and a bigger one, how that would work. And I cared for a woman that had your same scenario. I cared for a woman that had that same scenario once before, and she had a breech on board that she had a cesarean for, and she went forward to have 2 or 3 more children. I know 2 with me. I don't know if she had any others when she moved, but she had fine deliveries afterwards. So it would be something to consider. For me, I would want to do some research on that to be able to say to you, let me look at this. Let me understand better what was going on with you before I could make a suggestion to you. All right, let's bring some more questions. Thank you for asking that one. More questions. I know you're thinking about it. Okay. So, did we miss any? No. Okay. How about over here with everybody? Oh, great. So, being able to understand when you are talking to other women, other birth givers about having their babies, one, we want to prevent a cesarean from happening in the first place. And part of that is having good education, getting your nutrition well, and doing those P's that I mentioned, making sure the passageway is good, the passenger is lined up so that the power can work well, and the passion and the purpose is there behind it. When you put those together and you hire yourself a care provider who really wants to believe and trust in you, and or you have a care provider that can do their job, but you have a doula or a midwife to help you with that if you're going to a hospital or even to a birth center, that can give you that support, that encouragement that you're doing a great job, and resources of maybe things you could do that could help shift things, you're going to have the best opportunity to prevent having a surgical delivery. When a surgical delivery happens and you go for the second, you have to put yourself in the best possibility to maximize that opportunity for you. Because we know that once you've had a cesarean, if you have a second cesarean, it becomes even more difficult to find care providers who will give you the opportunity to attempt a vaginal birth. Now, some will. Some will allow you to attempt a vaginal birth after 2 or 3 or 4 or 5 even. But that's very, very rare, and there are risk factors that add to that. So if you are one that wants to have a big family, do whatever it takes to avoid having a cesarean, unless that is the best choice for the baby or you. If there were health problems or something that was definitely a problem, a cesarean is a wonderful option that we have available to us in modern medicine. It used to be that when we looked at statistics throughout just the general populations, that cesareans should be under 10%. In our United States, it's roughly 33%, and that percentage sometimes goes up a little bit. I don't know if it's managed to come down. One time I saw it at 29, but 33, 35, and there are some hospitals in our United States that have a 50% cesarean rate. One of the things that we do see is that there's about an 80% rate of epidurals. So that alone can cause those interventions to start, because an epidural, we are told, takes the power that the body can utilize down about 40%. So you have about 40% of pushing power, 40% of contraction power without adding in Pitocin. And there you go. You start adding these mixes up. And my coined phrase that I love is if you complicate birth, birth becomes complicated. And so keep birth simple. Start out by making it simple. And gain education, gain your wisdom to begin trusting what you know, what your body innately knows, and start reframing your mind and your head to use the nature that was in there instead of perhaps what is in society's mindset. All right. Hi, Clem. I had an emergency C-section due to an induction at 41 and 2 with side attack. Baby went into distress. General anesthesia cesarean. Oh, I'm so sorry with that. If I go overdue again, what if my provider pushes for inducing me again? Great question. Okay, so when a cesarean occurs because there was an induction, because of overdue, what we would look at is, one, understanding that your baby went into distress. We say, why, right? Did the baby go into distress because there was just side attack on board? Did they add Pitocin and things got to be too much for the baby? Did you end up on an epidural as well, which means that the baby was having a hard time being able to coordinate all of the different things, and the baby finally said, "Uncle, please get me out," which they did in order to get the baby out safely. So that's great. So how do you prevent having to have that again? One, make sure your dates are really clear. Because if you have longer cycles instead of a 28-day cycle, yes, ended up on an epidural due to intense contractions. Yep. So when you look at due dates, you have a last menstrual period, which is a date that most people know. Then you have the next menstrual period. So if it's 28 days, then you're supposedly scheduled on a 40-week pregnancy. And that due date is put, and remember it's called estimated due date, right? Because babies are due from 37 weeks to 42 weeks. And when you look at your cycles, if your cycles go 35 days, you ovulate later, so you should add an extra week onto that. and then your due date is actually a week later. So make sure your due date is scheduled or calculated appropriately. I do realize that most women who go into a hospital setting, they usually have an ultrasound between 6 and 9 weeks. Those early ultrasounds are supposed to be fairly accurate within about 3 to 5 days. And so 3 to 5 days can really make a big difference when we're talking at 41 weeks and 2 days, right? So we have to be aware of how those dates are calculated. So we look at that, we look at those dates, and if women always have 41.5-week babies, we know that that may be what their body tends to do. Now, by law in California, I can only do babies until that 42-week mark. So families know that if they want to have their babies at home, we have to get the baby born by that date, or I have to transfer them out of care. So what do? If we know they've had babies overdue, such as this viewer mentioned, we are proactive. And so we put all women on evening primrose oil. Everybody, doesn't matter what their dates were. We put all women on evening primrose oil starting at 35 weeks. If they've had premature babies in the past, we start them at 37 weeks, just in case their body is a little more receptive to those prostaglandins. So we ask them to take about 1,300 milligrams of evening primrose oil to help their body naturally want to ripen, help their cervix to want to be really stretchy. If there are due date issues, we may also let them know they can take an herb called black cohosh tincture starting at 38 weeks or at 40 weeks. Now, I'm telling you the generalities from clients in my practice, and you need to be mindful. I don't know you or any of our people that may watch this, your health, your circumstances, or anything. So please make sure that you talk to somebody about your individual circumstances. Black cohosh tincture is a great way in our practice for women to take it on a nutritional basis 4 times a day, 1 dropper full, starting at 38 or 39 or 40 weeks, that helps their body want to ripen up if they are one that has a tendency to go overdue. Because when we've had to do natural ripening for women who are planning to have home births, and or we may know that we're getting to that 41-week mark and we know that 42 is coming up and we have to get this baby born, if the family is choosing to want to have a natural induction, which basically means herbs, homeopathy, sometimes stimming their cervix up with a little bit of stretching, and yes, castor oil. But then labor starts, baby comes out, everybody's well, and they've had their birth and things have gone at home instead of going in for the inductions with Pitocin and everything else. So this is where there are choices, there are options to helping them ripen up and want to get there. Now, one of the things that we've had in our practice is probably since 18 years ago, I have never had to have a woman go in to have an induction because she went over 42 weeks. Now, part of that is in getting them ripe enough and into labor before that time happens, because that was their choice. They could have just waited, gone to the physician and had a hospital induction, but they wanted that. And the other part of it is that very rarely do we have to get that far that we're pushing the date so far that we have to do all of that. But we know we can. We know we have those tricks to the trade. And if for some reason labor goes along but it just won't progress, we are going to go in anyway. But we also want to make sure that that baby's in a good position, you see? Because if babies aren't in good positions with their backs up front, they sometimes do funny things. There's even what's called a pendulous uterus, and we see that with women who may have had a few babies, or maybe they had twins at one birth and now they're having a singleton and their uterus lays out and their baby lays out, and it doesn't keep the baby in their body, which means the baby doesn't stay on their cervix, which means birth doesn't ripen as well. So what do? We help put them up into a belt and the baby drops into the cervix and it starts ripening everything. And so as midwives, we're looking for these cues that are going to help with that. Okay, we have another viewer. 3 babies, 3 home births, 41 weeks, 40 weeks, and 39 weeks. Right on. Way to go. So yes, part of it is how the different teams versus a midwifery team versus a physician team view how pregnancy, birth, dates, and inductions work. Okay, so that's some of the differences, and that's why I say if you've had that before and you still want to plan to have a hospital birth, great. Maybe you want to just sit and talk with a midwife about what all of the other options you might have so that they can understand what your specific health concerns might be. Thank you so much. I'm in North Carolina currently, 12 weeks with number 2. Congratulations, and switching from OB to CNM support. Right on. So that's going to help a lot. Just like I said, keep your research going. Look at all the other things. Don't hesitate to get on any of my lives or, on Instagram. I have all my 40 P's of pregnancy, which really goes across everything. Those are very brief. And coming up probably the latter part of June, my whole entire childbirth education series is going to be online. So we'll be letting you know about that. Another viewer, it makes me so sad to see so many people, scheduling their birth to whatever reason. So thankful for midwifery with CNMs. Right on. Could you? Yes, because being able to, when some say, but I want my baby born on January 1st and I'm due on the 7th. So let's just induce me so I can have a New Year's baby. Your baby didn't intend that. If the baby comes that day, great, wonderful celebration. But what it puts you through and your baby through is something that your body and the baby are not clearly ready for. And it may put you down a path that you didn't want to go down. So really trust your body to understand when it wants to go into labor within, the parameters of things. And also understand that emotions can play with that. And you'll find that sometimes when you go overdue, we have said to women, take the day off. I don't want you to have the baby today. Maybe they're 41 and 2. Say, I don't want you to have the baby today. I want you to do nothing but have a carton of ice cream, a nice hot bath, go out for a walk and a movie, and I don't want you to even think about having the baby today. And let's pick up that tomorrow. Because sometimes you just have to let go and let your body be able to do what it needs to do, because you can feel so stressed about, come on, it's time, come on, come on. And oxytocin just doesn't work real well that way. It's no different than if you go, hey, I need you to have an orgasm right now, right now, right now. And you'll be like, I can't do that on the clock, okay? So that's a lot what birth is like too. All right, let's see. Speaking of supplements, could you speak on dandelion root? Oh, one of my favorite herbs. I would love to. Dandelion root is an herb that helps balance sodium potassium. It helps keep the kidneys wanting to clear and the bladder clear. And it has been one of the best supplements that we have used in our practice with all women to help keep that blood pressure happy, the liver happy, because it's a liver nourisher also. So it works on the liver and the kidneys. And your liver and your kidneys are filtration organs, and those filtration organs have to be kept happy, healthy, and well. And so we use those. We have them take 1 capsule of dandelion root per day for every 2 months they are pregnant, unless there are concerns. If they get swelling, if their blood pressure goes up a little bit, we increase it. And we have it in our tea. We have dandelion leaf in our tea that we have them drink, and it's really a wonderful tool. Excuse me. If their blood pressure tends to start going up, we use other herbs as well as magnesium. We use passion flower. We up their dandelion. We make sure that they are really focusing on their protein. We monitor it, keep it within a good range. And so far, we've been able to keep all women within our practice. We have not had to transfer them out because of high blood pressure issues. I can see my little flasher going on, which tells me that we've probably got about 5 minutes left, and then we have to shut things down. And please ask me if there's another question about the dandelion that you wanted to have me go over with that. It's great. Now, some people will say, can I use milk thistle in exchange for dandelion? Although they're very similar in perhaps what you read, I have found for my personal use in pregnancy that I like dandelion. It seems to be gentle and it seems to be a good nourisher. And milk thistle for me has tended to be a little more detoxifying. I've seen just a little more reactions. Now that may be just my relationship with that particular herb. So I like dandelion better than milk thistle. Sometimes you find them in combination, but that's been the one that I've been the most happy with. Interesting. HBAC here. So I did have one comment from a viewer that she said an HBAC is very dangerous. Having a baby at home and having a VBAC at home, I want you to know, is a very safe option, providing that you have good care providers who are very skilled in it, that you have monitoring, that you are healthy, and that things go forward well. There are things that would never be done at home, like Pitocin, epidurals, internal monitors. Nothing like that would ever get done at home, so those risk factors are much less compared to in a hospital setting. And it isn't for everybody. I'm saying that that option is available if that is something that a person would like to do, making sure that they have a good, skilled care provider. And if the birth giver doesn't feel safe about birthing at home, they should be in a hospital, because that's where they're going to birth the safest, and that's where they're going to feel most comfortable. All right, any other questions? Otherwise, I'm going to close us down here pretty quick. But thank you for bringing that up so that I could talk about it. Okay. All right, so thank you so much for joining me tonight. This has been a wonderful topic. I'm sure that we'll talk more about VBACs in the future. And thank you for your comments, both of them. And I just want to close to remind you about these beautiful, beautiful children that all of this pregnancy and birth is all about. Go in, hug your children, tell them that you love them. Tell them they're amazing and that they can do anything they set their mind to. So until next week, have a wonderful week. Enjoy the sunshine, enjoy the rain, enjoy anything that your family does that brings you joy. Bye for now.